section of Medical Club. Today's presentation from the Departments of Anatomy and Pharmacology. The chair for today's both presentations is Dr. Cyril, HOD of Plastic and Reconstructive Surgery Department. I warmly welcome sir to please chair the sessions.
Good morning, all of you. Two topics today. One is the functional anatomy of the facial nerve, and the second on antimicrobial resistance. The anatomy of the facial nerve, functional anatomy, is something which is very close to plastic surgeons, something which gives very good results in facial nerve palsies. And it's important to know the functional anatomy to plan out surgeries and also to assess what results we might get. So,
good morning all of you. I am Amal, Department of Anatomy. My topic is functional anatomy of facial nerve. I am just focusing nuclear origin, course and distribution of functional anatomy. Facial nerve. Nuclear origin and intracranial course. The location of facial nerve nuclei in the pons. The facial nerve functional nucleus are located in the pons and medulla. There is a four functional nucleus are there: motor nucleus, superior salivatory nucleus, nucleus of tractus solitarius, and lacrimatory nucleus. This is the posterior view of a brainstem, and this is medulla, pons, and midbrain. And the motor nucleus are, this is a motor nucleus, and this is superior salivatory nucleus. This is a nucleus of tractus solitarius, and this is lacrimatory nucleus. The motor nucleus are located in the caudal part of the pons and behind and in front of the abducent nucleus. It carries special visceral efferent fibers. The superior salivatory nucleus are located on the dorsolateral to the motor nucleus. This is the superior salivatory nucleus. It carries the general visceral efferent fibers. The nucleus of tractus solitarius, this is the nucleus of tractus solitarius, it carries the special visceral afferent fibers. Then the lacrimatory nucleus. The lacrimatory nucleus located near the salivatory nucleus, it carries the general visceral efferent fibers. Facial nerve is a mixed cranial nerve. It carries the four functional type of fibers. First one is the special visceral efferent fibers. It supplies the muscles of facial expression, stapedius, posterior digastric and stylohyoid. The general visceral efferent fibers, it carries the parasympathetic and secretomotor fibers. It will be described later. And special visceral afferent fibers, it is a taste sensation. It receives the taste sensation from the anterior two-thirds of tongue, while the chorda tympani nerve, and also from the soft palate through greater petrosal nerve. The next one is the general somatic afferent fibers. It receives the general sensation and proprioception. The sensation from the small area, including the skin behind the pinna, external acoustic meatus, and tympanic membrane, and the proprioceptive impulse carried from the facial muscles. Next is the motor fibers. This is the section of a pons, and this is the ventral aspect of a brainstem, and this is the dorsal aspect. And this is motor nucleus, and this is an abducent nucleus. The axons start from the motor nucleus of facial nerve. It passes dorsomedial to the floor of the fourth ventricle, caudal to the abducent nucleus. The fibers ascend medial to the abducent nucleus and curve around the rostral fold, forming an internal genu of the facial nerve. These loop create a visible swelling of the floor of the fourth ventricle is called facial folliculus. Emergence from the brainstem and components. This is the ventral aspect of a brainstem. This is medulla, pons, and midbrain. And the facial nerve arises from the pontomedullary junction. This is the pontomedullary junction. And the facial nerve consists of two roots. One is the motor root and another one is the sensory root. This is a motor root and this is sensory root. The motor root is a thick and large and it carries the motor fibers. And this is a sensory root. This is it carries the sensory fibers. It lies medial to the vestibulocochlear nerve. This is the vestibulocochlear nerve. And these facial nerve enter into the internal acoustic meatus. This is the cranial cavity, and the cranial cavity is divided into three parts: anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. We can see this is the petrous part of temporal bone, and this is the opening of internal acoustic meatus. The opening of internal acoustic meatus. This is the cadaveric image. In the internal acoustic meatus, the facial nerve are entered into the internal acoustic meatus or facial canal. The course in the internal acoustic meatus. The motor root and sensory root or nervous intermedius and vestibulocochlear nerve enter into the internal acoustic meatus along with the labyrinthine vessels. This is the interior structure of a temporal bone, and this is a pons, and this is the vestibulocochlear nerve and the facial nerve. They are entered into the internal acoustic meatus. The inside the internal acoustic meatus, the facial nerve, the motor root and sensory root are merged and form a single trunk. The facial nerve lies in the anterosuperior quadrant of the internal acoustic meatus fundus. This is the arrangement of facial nerves and vessels. This is superior labyrinthine vessels, and this is motor root of facial nerve, and this is the sensory root of facial nerve, and this is vestibulocochlear nerve. And the sensory root lies in between the motor root and the vestibulocochlear nerve. Then the intratemporally, the facial nerve is divided into four segments: meatal segment, labyrinthine segment, tympanic segment, and mastoid segment. The meatal segment extended from the opening of internal acoustic meatus to fundus of internal acoustic meatus. And the labyrinthine segment is the shortest and narrowest segment. It extends from the fundus of internal acoustic meatus to geniculate ganglion. Then tympanic and mastoid segment. This is the lateral view of a petrous part of temporal bone, and this is the promontory of middle ear cavity, and this is the tympanic plexus. In behind the middle ear cavity, this is the tympanic part or vertical horizontal part. In the mastoid part run vertically downward to the stylomastoid foramen, the geniculate ganglion. The first sharp bend or external genu. It is a storehouse of a cell body for taste from anterior to the left tongue and the general sensation from the skin behind the pinna, external acoustic meatus and tympanic membrane. And this is the geniculate ganglion. This is the first sharp bend of the facial nerve or external genu. This is a surgical landmark for the processus cochleariformis. In this diagram, this is the processus cochleariformis. Next one is the tympanic and mastoid segment. This is the middle ear cavity diagram, and this is the promontory and tympanic plexus. And above the promontory, this is the prominence of a facial canal, and above the facial canal, there is a prominence of lateral semicircular canal. In this diagram, this is the promontory and tympanic plexus. This is a rounded window, and this is stapes. Then this is bulging or prominence of a lateral semicircular canal. And this tympanic part lies above the promontory and below the tympanic, below the prominence of lateral semicircular canal. Then initially the tympanic part is curved around the oval window, and anterior and inferior part of the lateral semicircular canal. They can go and take the next genu or second genu. Then mastoid segment run vertically downwards to the stylomastoid foramen. Then stylomastoid foramen located in between the styloid process and mastoid process. In infant, the styloid foramen is more superficial as the mastoid foramen is not developed until the late in the year of the second year. The intratemporal branches. The intratemporally, the facial nerve gets three branches. One is the greater petrosal nerve, and this is geniculate ganglion. One branch is the greater petrosal nerve, and the mastoid segment is the two branches. One is the nerve stapedius and chordae nerve. This is an orthoscopic view. You can see the chordae nerve crossing the tympanic membrane at the angle of the malleus. Next one is the extracranial force branches and distribution. The facial nerve emerges at the base of the skull at the stylomastoid foramen. Then emerge at the stylomastoid foramen the entry of the styloid branch of posterior auricular artery. The immediate extracranial branches are posterior auricular nerve, and to the posterior belly of digastric and stylohyoid muscle. Next, the pores within the parotid gland. This is the parotid gland, and this is posteromedial surface, and this is an anteromedial surface, and this is superficial surface. In the facial nerve enter into the posteromedial surface of parotid gland and divided into two trunks, superior trunk and inferior trunk. The superior trunk is called the temporofacial trunk, and the inferior trunk is called the cervicofacial trunk. These two trunks are united to form a plexus. That plexus is called the pes anserinus, and these trunk and plexus are like superficial to the retromandibular vein and external carotid artery. The terminal branches. The facial nerve emerges from the anterior margin of the parotid gland, and the branches are temporal branch, zygomatic branch, buccal branch, and marginal mandibular and cervical branch. The branching pattern is highly variable. 6 distinctive anastomotic patterns have been classified. 1 to 6 type. This is the type 1. This is upper division, and this is the lower division. This is temporal, zygomatic, buccal, marginal mandibular, and cervical. The type 1, the absence of anastomosis between upper division and lower division. Type 2, the anastomosis only between the branches of upper division. Only in upper division. Type 3, the single anastomosis between the branches of upper division and upper divisions. Then type 4 is the combination of type 2 and type 4. Type 5 is the double anastomosis of divisions, and type 6 is the complex anastomosis. Temporal and zygomatic branches. The temporal branches emerge superiorly, crosses the zygomatic bone, zygomatic arch, and supply the frontal belly of occipitofrontalis, orbicularis oculi, and curvature muscle. Then zygomatic branch is crosses the zygomatic bone to the lateral canthus of eye and supplied by the orbicularis oculi. Buccal branch. The buccal branch is typically multiple in number, run above and below the parotid duct, supply the buccinator, orbicularis oris, and levator labii superioris. Marginal mandibular. The marginal mandibular emerges from the antero-inferior to the parotid gland and runs anteriorly. This is the branch at risk during the surgery involving the submandibular or incision near the lower border of the mandible. When posterior to the facial artery, when the nerve is always lies inferior to the lower border of the mandible. The surgical precaution, the regional incision are advised to be at least 1.5 cm below the lower border of the mandible to avoid the injury. Cervical branch. The cervical branch emerges from the lower part of the parotid gland, and it's run inferiorly and supply the platysma muscle. Parasympathetic pathway passing through the facial nerve. Secretomotor pathway to lacrimal gland. Its origin from the lacrimational nucleus, and fibers go through the nervus intermedius, and preganglionic fibers travel by the geniculate ganglion and to the greater petrosal nerve, and the greater petrosal nerve join into the petrosal nerve to form a nerve to pterygoid canal, and the preganglionic fibers are entered into the pterygopalatine ganglion, and postganglionic fibers goes to the maxillary nerve, zygomatic nerve, and lacrimal nerve, and leads to the lacrimal gland. Then secretomotor pathway to the submandibular and sublingual salivary gland. It originates from the superior salivary nucleus, and the preganglionic fibers travel by the nervus intermedius. Then fibers leave as a chorda tympani nerve, and this chorda tympani nerve join into the lingual nerve. Then they can reach into the submandibular ganglion. The postganglionic fibers supplied by the submandibular salivary gland and the sublingual salivary gland. This is the diagram of lacrimal. Next, clinical anatomy. The nerve injury location and symptoms. The lesion proximal to the geniculate ganglion affect the tear formation, stapedial reflex, taste and the facial movements. The lesion distal to the stapedius branch, spare the stapedial reflex and no hyperacousis. The lesion distal to the chorda tympani, spare the taste and salivation, affect only the facial muscles. The bell palsy. It is an idiopathic locomotor neuron facial palsy, accounts for the 75% of all facial palsy, probably results from the herpes simplex viral infection causing the nerve swelling and compression between the temporal bone. The result in the complete ipsilateral paralysis of the facial muscles and differentiated from the lumen lesion, upper face spared due to the bilateral cortical control. Cerebellopontine angle pathology. The nerve can be damaged at the cerebellopontine angle by tumor. The location of the tumor at the cerebellopontine angle is the facial nerve directly at the during the surgery procedure in the excision. In the case of the large excision, the vestibular schwannomas larger than the 4 cm that require excision. It is often difficult or impossible to preserve the facial nerve function. Nerve block and trauma. The nerve block. The temporary facial nerve palsy can occur following the inferior alveolar nerve if the needle is placed through D or solution spread near the parotid gland. The trauma. The nerve is vulnerable to injury in the temporal bone fracture, damaging in intratemporal segment. The facial trauma, laceration, damaging